Welcome, everybody, to Liposarcoma 101. During this seminar, all participants will be in a listen-only mode. At the end of the presentation, we will be able to ask questions, and you can submit them throughout the presentation in the Q&A feature at the bottom of your screen. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. I'd like to introduce myself. My name is Sarah Rothschild. I am the Executive Director of the LifeRaf Group. The LifeRaf Group has been around for over 20 years, providing education, support, and advocacy for sarcoma patients all around the world. We recently started the Liposarcoma Support Network to provide a community for liposarcoma patients. And I would like to introduce Christina Wang, who has been instrumental in the creation of this program, as well as Dr. Samaya.
Good afternoon, everyone. It is my absolute pleasure to kickstart the Liposarcoma Network's first Liposarcoma 101 lecture. I know that a lot of you are here with perhaps different types of liposarcoma. I'm going to go over, going into the, well, those are my disclosures, but none of them are related to the talk today. The goals for today's lecture is really to enhance all of our understanding, or all your understanding, of the various types of liposarcoma, because a lot of times you will see extensive literature or even in clinical trials them clubbed together, but this does form a very heterogeneous group of diseases that are very distinct. So it's good to have that understanding, because a lot of you might not fall into just one of the categories. So I'll try to point out what is specific to each of the subtypes of liposarcoma as I go through the talk. I hope that after this lecture, I mean, again, it's a lot of information here, but I hope that all of you can take away a basic understanding of the treatment approaches for these various types of liposarcomas. We did get a request, and this is just hot off the press, quite disappointing in some ways, but this Bright Line 1 study, which is specific to dedifferentiated liposarcoma, I'm going to go over some of those results. And even for those who don't have dedifferentiated liposarcoma, it kind of gives you an idea of trial design and how we try to get to our objectives. And I definitely hope to have time for question and answers. And I was going to say, I'm going to answer as many questions as I can. If we run out of time, you can always submit your questions. I will answer them via email through Sarah. And I have to start my video. Okay. So this is just an overview of sarcomas. Approximately why we call ourselves rare is it's only 15,000 new cases per year in the United States. So 1% of all cancers. And depending on whom you ask, there are around 50 to 100 subtypes, and more if you go into genomic variants within each subtype. So it makes, each of the diseases very unique, and the need to study them in that unique fashion to try and get the best outcome. And approximately 50% of patients will present with or eventually develop metastatic disease, which means disease that has spread, so it's not easily resectable or treated by surgery. Sarcomas, the reason we term it as sarcomas is because they arise from mesenchymal cells. And these tumors can differentiate along the lineages of either fat, muscle, nerve, blood, or lymphatic vessels, bone, or cartilage. And that's where the terms of like liposarcoma or muscle leiomyosarcoma or rhabdomyosarcoma, nerve is, nerve sheath tumors. So some of the terminology is derived from their cell of origin, not all of the sarcomas, but for some of them. And because you have connective tissue or mesenchymal cells all over your body, these tumors can occur anywhere in the body. A little bit about as I said, the different subtypes within the liposarcomas, also known as adipocytic tumors, because they're fat derived, or we think some of them resemble fat or are derived from fat. Lipomas is important to know. A lot of us might have like little fatty lumps that we've had for a long time that you could feel under your skin. They can usually fall under lipomas, which are benign proliferation of mature fat cells. They're not a malignancy, and they do not become malignancies. So no treatment is necessary for them. Some patients, if it's causing a cosmetic issue, could have them resected. But when you go into anything that's growing or liposarcomas, and it's very important not to assume something is a lipoma unless it stayed stable for many years and you have that information, it's small and is very mobile. But otherwise, if there's any other mass that is having any signs of suspicion, it's always important to evaluate. Because liposarcomas are a malignant proliferation of these mesenchymal cells, and liposarcomas are a very common subgroup within sarcomas. There are 20% of all sarcomas, roughly 3,000 new cases per year in the US. Now, what are the persistent unmet medical needs? Unfortunately, that's why we all are, in the academic world of sarcoma, all of us across the nation and the world, also in sarcoma centers, are working towards trying to improve outcomes, because there is a very high rate of disease recurrence, which means, your tumor was removed and now the tumor comes back. And this ultimately leads to death from disease, despite upfront treatment with surgery or other chemotherapy some might have received with their surgery. The rate of recurrence can be high. There is also delayed identification and diagnosis due to barriers in accurately identifying and diagnosing these types of liposarcoma. As you can understand, a lot of times, people in the community might not be aware that this could be a sarcoma, let alone a liposarcoma. So that's why increasing that knowledge and making sure that, once a problem's identified, the diagnosis can be expedited and you can get to an expert center sooner is in the patient's best interest. And there is still, outside of the pockets of sarcoma expertise, there is limited knowledge about the emerging treatments for these tumor types, because they're rare. It's not that the physicians are not capable or smart, but they just don't have the experience because they might not have seen as many of these tumors. So the different types of liposarcoma that I alluded to earlier. So one of the subgroups is myxoid liposarcoma, and this makes up around 30% of liposarcomas. It is characterized by, what we call a translocation. So we have these 23 chromosomes, and chromosome 12 and 16, they tend to, intermix, like they go crisscross on each other, and then they separate, forming a new little protein or a new fused protein that is abnormal. And this particular protein, in majority of cases, is fused CHOP, which is between 12 and 16, chromosome 12 and 16. And either fused CHOP or EWS CHOP, both of them work as a transcription activator. If you go back to biology, transcription is when the DNA is making protein, makes mRNA, and then to mRNA is transcription and then translates it to protein. But these are transcription activators, so it starts activating genes that then lead to production of molecules that can lead to the cells, telling the cell to divide. So myxoid liposarcomas also can be associated with certain mutations like the PIK3CA. What is important to remember is the difference in the way we approach these, because myxoid liposarcomas, among all the liposarcomas, are the ones that are very sensitive to chemotherapy. The response rates can be 50 to 80% with traditional chemotherapy, which is based on doxorubicin or trabectedin, and we'll talk about these agents a little later. And myxoid liposarcomas normally is found in the extremities, but they could spread to any other fat-bearing areas in the body, including the spine, the abdominal cavity, etc. Now, pleomorphic liposarcomas are rare. So these are, only less than 10% of all liposarcomas, and they tend to have this alteration. So as you can see when I'm talking about it, because now we can genomically classify them as separate. Not only previously, they used to be classified separate just based on how they looked under the microscope by the pathologist, but now we also have a lot of genomic data that tells us or points us to one direction or the other. So these tumors generally have TP53 mutations, and P53 is a tumor suppressor. So if it's mutated and not working well, then there is a more chance of forming tumors. And these tend to be less sensitive to chemotherapy. Then moving to the biggest category, what we call well-differentiated and dedifferentiated. It is actually, you could call them one subtype or two, but they're basically the spectrum of the same. They have the same molecular changes, and we'll talk about that in a bit. But well-differentiated liposarcoma is the end of the spectrum that is more towards being low grade. They tend to be slow growing or just minimally growing, and they can get to very large sizes over a significant period of time. They're usually like fat cells. In fact, on imaging looks like fat cells, but they do have some abnormal features like these pleomorphic nuclei or very big appearing fat cells. They generally are thought to not cause metastases. And metastases, again, means when it spreads through the bloodstream or lymphatic system to other organs. So the well-differentiated liposarcoma rarely, if ever, metastasizes. But within that spectrum, you could be very low grade, or you could be a little bit more cellular or sclerotic, what we call these hypercellular or sclerotic or immune infiltrated subtypes of well-differentiated liposarcoma that could behave more aggressively, even though they fall under low grade. And these tumors, the primary modality of treatment is surgery, and some of those can be just treated with surgery alone and hopefully don't come back. But even then, it's very important to follow these patients because they do have a propensity for recurrence. And over time, whether it be many years, they could recur, and they could recur as a more higher grade variety, dedifferentiated liposarcoma. So this is just it looks pretty, a picture which is under the microscope, and what you can see is these empty nest-like cells, and that's basically fat cells. But what you see is there are multiple nuclei in between these fat cells that with these very big abnormal looking cells that tell us that this is a well-differentiated liposarcoma, not just fat. Then moving to the dedifferentiated liposarcoma cohort, again, this group of well-diff D-diff is the majority of all liposarcomas. So I'm assuming a lot of you online might fall into this category. And the dedifferentiated ones are more aggressive, so they appear more solid on imaging. And they do have a propensity to spread to other organs like the lung, even though the highest risk is to recur in the same area. But they can spread to other organs in around 20% of cases. These tumors, unlike the well-differentiated liposarcoma, the dedifferentiated liposarcoma can respond to chemotherapy, but it's still limited. I just talked to you about myxoid liposarcoma, where the response is 50 to 80%. Here, the responses are more in the 20% category. The most common location of the dedifferentiated liposarcoma is what we call the retroperitoneum, which is the area right behind where all your bowel loops are sitting. And that retroperitoneal cavity can extend all the way up in the abdomen, all the way down to your pelvis, and into the fat can extend into the scrotum as well. And this is, you can see, very different from the well-differentiated liposarcoma. You see much more cellularity. So the pathologists make a determination based on how pleomorphic the cells appear to see if there is dedifferentiated or dedifferentiation present. As I said, these both well-different, and there's some abbreviations, so just follow with me. Well-diff liposarcoma is WD-LPS and DD-LPS. I've used that throughout. But despite their striking difference in appearance and behavior, they do share the same genetic alterations. They have these giant ring chromosomes. So unlike the translocation with myxoid liposarcoma I talked to you about, here there is no translocation. The mutations, it's not mutation driven, but you have a section of chromosome 12, which is between chromosome Q13 to 15, that segment that has genes like MDM2 and CDK4, which are oncogenes. You tend to form ring chromosomes, and it's through this process called chromothripsis. And so you have multiple copies of these genes, which are oncogenic. And because you have multiple copies, they're able to suppress tumor suppressors and cause the tumor to become basically malignant. Yeah, but what is important to remember is, though these tumors, almost all of them, it's almost characteristic to have MDM2 amplification. As you can see, this is a fish. You can look for this MDM2 amplification by different mechanisms. We won't go into that right now, but usually the pathologist can do it fairly easily. But it's not unique to liposarcoma. So there are a lot of other tumor types, but this particular tumor type, it's almost 99% that, or almost 100% that they will have this. What is important to know that well-diff and D-diff liposarcoma can coexist. Again, I don't know if you've ever looked at an imaging. So this is almost at the pelvis. The white stuff is your bone. This is a patient lying on a table. And this is a cross-section in their abdominal cavity. And what you see here, so you can see the subcutaneous areas are like, what normal fat looks like, this dark with some striations. The well-differentiated liposarcoma just basically looks like that, except that you shouldn't have this big blob of fat in here, and that's not normal. Sometimes people just present with, they just thought they were getting more abdominal girth because of age and getting fat, but then they discovered later that they had a tumor inside. Sometimes it can just look like that even on the outside. But here, what you look on the right-hand side, we see what we call dedifferentiated, or this is, again, not always, but majority of the times when you see something solid like this, which is taking up contrast, which is the contrast you get through your IV when you get a CAT scan. If it picks up contrast in high amounts, you'll see them as solid, and those tend to be having the more cellular or a higher grade features. Another way of telling them apart, again, PET CT scans. So this is a PET CT where you see in the bottom with the orange bright spots. PET CT scan is always not required for well-differentiated, dedifferentiated liposarcoma, but if there is a confusion, if there could be dedifferentiation, sometimes a PET CT scan can light up in areas of more higher grade tumor. So it might help us to differentiate. Because you can imagine, you have a tumor here and a tumor here, and if you biopsy this or this in this area, which is not very bright on PET, you will get well-differentiated liposarcoma as your diagnosis. Instead, if you're actually going to biopsy this area instead of this area, you're more likely to get the correct diagnosis. And the reason why we're focused on getting, if there is dedifferentiation, we want to identify dedifferentiation, is because that is the more higher grade variety, and we want to make sure our treatments are focused on the more higher grade variety to give you the best outcomes. So for baseline workup and diagnostic assessment for any type of liposarcoma really is that you need to do imaging to assess the extent of disease. It usually involves the area where the primary tumor was first detected, but also we make sure we get the chest, abdomen, pelvis extent. And if the tumor is actually in the extremity, then also the imaging of that extremity. If you present with a mass that is just localized and we look at the features and that looks suspicious, one might go to surgery directly. But most of the times you will get a biopsy to prove what it is, because sometimes, we want to make sure we're identifying the right type of tumor. There could be other types of tumors in the abdomen. And then, as I mentioned in the previous slide, we try also to make a concerted effort to figure out if there is higher grade dedifferentiation present or not. And then we go towards the treatment approach. We always involve a multidisciplinary team. You need the surgeon's input to know if it's resectable as it is. What is the morbidity, which means the side effects of getting surgery? How much, are you going to lose a kidney? How dramatic is it going to be? How close the margins are going to be. With that, we decide if we need additional chemo or radiation along with that surgery in order to treat it. And unfortunately, if you present with very bulky disease, or if it is spread already, then sometimes we need to start with systemic therapy, which is the mainstay of treatment. So what is the optimal initial management of liposarcomas? Again, surgical removal of the primary tumor. And in the case of well-diff, D-diff liposarcoma, if you have a recurrence in 3 years, 10 years, some people can have serial surgeries because each of the recurrences is still operable, and it hasn't changed trajectory. If your recurrences are happening very infrequently, then surgery alone might be enough. But once that frequency of recurrence becomes more quick, or it starts becoming more extensive, then doing another surgery might not be of benefit. And we, as I said, on a case-by-case basis, we will decide whether we need to do preoperative, which we we use the terminology of neoadjuvant, or if we do postoperative, which we call adjuvant radiation therapy. We usually use radiation for the extremity when it's localized. In the retroperitoneal or abdominal space, it is being tested in clinical trials to see if that adds benefit. And again, mentioned here is in retroperitoneal tumors, it's of less clear benefit, but as I said, it's still being investigated. This is just another cross-section image to show, this is looking at you from the front, the patient from the front. This is the liver, this is the kidney on both sides, this, and on this side, you could see that there is this kind of more solid appearing mass, but all the way around this kidney, there appears to be extra fat around this kidney, which you don't see on this side. And that is the well-differentiated or lower grade liposarcoma. Again, the different liposarcoma subtypes, when we are thinking of advanced disease, if your disease has come back or spread, or you need systemic treatment, the way we decide systemic therapies is quite dependent on the type of liposarcoma. So, AI is the abbreviation for adriamycin ifosfamide. We have other slides that I'll go over some of that data. I'll try to simplify it. And sorry if it's a little complicated. The other treatment that we use often is gemcitabine docetaxel, usually used in the second line, especially in dedifferentiated liposarcoma or pleomorphic liposarcomas. And for myxoid liposarcomas, we often use trabectedin, which works very well. It's also useful for the other types of liposarcoma, but it works the best for myxoid liposarcoma. On this slide, again, the one thing I'll point out, not that you need to, it's all patient dependent, depending on what you've got before we decide what's the next thing. But for myxoid liposarcomas, I'm not going to go into too much detail into the T cell therapy options, but cellular therapy has a role in myxoid liposarcomas. It's being actively investigated, and it is applicable for a subset of myxoid liposarcomas that have advanced disease because they have markers on their tumor that you could target through this cellular therapy. So I'll leave it at that because that will, it takes more time, but maybe at a future talk. I want to spend some time talking about adriamycin or doxorubicin because a lot of times patients come in and I completely understand there are words like the red devil, that, oh my God, I'm never going to take that because it's horrendous. And it is horrendous. And I'm not trying to underplay the toxicity that is associated with these chemotherapies. But also, because we'll talk about the bright line data, there is still a value for this drug because it works. And so it is important to understand where this data is coming from and why your doctors would sometimes suggest that you go through this chemotherapy early in your disease process. So this falls under a category known as anthracyclines. These are DNA intercalating agents. They inhibit an enzyme known as topoisomerase 2. And this enzyme is responsible for relaxing DNA, the coiled DNA, and allowing for DNA transcription. So by inhibiting that, it basically is causing DNA damage and can preferentially hurt the tumor cells that are actively dividing versus normal cells. However, given that normal cells also undergo replication or transcription, you also have the side effects that we see with adriamycin or doxorubicin-based chemotherapy. And this is one of the first trial slides that I'm presenting, so you will see this often, but this is a trial which looked at giving doxorubicin by itself versus doxorubicin plus ifosfamide in patients with soft tissue sarcoma. The problem is, for a long time, the trials included all soft tissue sarcomas. And I have just explained to you that liposarcomas are first very different from other soft tissue sarcomas, but there are also various differences within the different types of liposarcomas. So when we look at a trial, it is very important to get the expert opinion of sarcoma doctors to figure out the nuances of the results that we see, right? Because the final outcome, one sentence doesn't summarize all the different possibilities for each of the subtypes of sarcoma. So this particular trial showed that the overall survival, so this particular graph that you see, the red line is what patients did with doxorubicin and the blue line is what patients did with the combination. The overall survival was not very different based on the number of patients they had. They had a little over 200 on each arm. And again, with a very heterogeneous group of patients on each arm, sometimes you're not able to detect a difference, even if there is. Plus, the overall survival can be affected by subsequent treatments you receive after doxorubicin. So we in the sarcoma world, we do accept what we call progression-free survival as a surrogate marker, a marker stating that if you don't progress, if the time you are without progression after that particular treatment is longer, that should correlate with overall survival. And hence we do accept improvement in progression-free survival or PFS as indication of that drug or drug combination being better. And here for the progression-free survival, the p-value was significant and the combination of doxorubicin ifosfamide was better than doxorubicin alone. In this particular trial, there were around 11 to 14% of patients who had liposarcoma. So again, we're extrapolating for liposarcomas, but I can tell you with other retrospective data that does apply as well. What is very evident is from all studies that have come so far are that the combination, you definitely get more responses. So when you look at a trial and you're looking at the rate of response, like here you have a rate of response of 27%, including complete response or partial response of 27% with the combination versus around 13% with the single agent. on trials, a response is assessed usually by if there is a more than 30% shrinkage in a unidimensional sum of all lesions that are measured, or they usually select up to 5 lesions. So basically up to 5 lesions, unidimensional sum. And then they look at how it changes with time. And if it drops below 30%, then you become a responder. So technically, understanding that stable disease is important as well, because if that stability lasts for long, if your tumors are shrinking, but they haven't reached 30%, it's still a great outcome. And that's important to know. So most of the times doing a trial in specific subtypes is tough because it's rare. It takes a lot of time and resources of patients. What we normally do is look at data of patients we have treated in the past, which falls under retrospective data where the outcomes happen and we're going back and looking at it. So it's not it's subject to biases, but it's what we call real world data. And for rare tumors, this is important. We do have, a bunch of trials in the liposarcoma space. One of them is our own data from MD Anderson. Dr. Livingston, who's on faculty now, was a fellow at the time when I gave him this project. But, when you look at the responses, again, even in the real world, we can look at this response rate as about 30% with combination adriamycin versus the response rate for D. diff liposarcoma specifically is quite low with adriamycin alone, though it's not zero. And we'll see that in the Bright Line study, that patients respond and patients derive benefit from single agent doxorubicin as well, but the response rate is higher, means shrinkage rate is higher with the combination. And this is another data showing the same thing, like adriamycin single agent 6% versus combination 22%. And not to forget the myxoid liposarcomas, I did mention we have retrospective data in that category, in that subtype as well, and response rates are much higher. So this subgroup of diseases is sensitive to both radiation and chemotherapy and used more frequently, especially in the advanced disease setting. Now, the summary of the adriamycin-based chemotherapy is that it remains the standard of care first-line therapy for patients with advanced disease. Combination therapy improves response rate and progression-free survival. So again, it might not improve overall survival because you can get other treatments after in sequence, but you need to get the surgeon's opinion, because if you're trying to downsize a tumor, make it smaller so that it becomes operable, and then that's why response is important, then you're going to select the combination. On the other hand, performance status and how you're doing, because it's very important that you maintain quality of life as well as you're going through all these therapies with the hope of living longer. And in that situation, we must balance the side effects that you get with the combination, which is very high compared to what you get with the single agent. So there's a lot of, we have to look at the goal of treatment, your current status, and where we want to be to make those decisions. The next treatment usually, so gemcitabine is again another DNA damaging agent, and there is data with this combination in soft tissue sarcomas in general showing that gemdocetaxel, which is a combination drug, was better than gemcitabine alone. And then there was another study looking at gemdocetaxel versus doxorubicin in the frontline study. And again, not specific for liposarcomas. This is all sarcomas put together, as I said, because most of the trials, we combine them for getting enough patient numbers. That here, gemtax as a combination was similar to doxorubicin as a single agent. So just saying that, doxorubicin as a single agent still has activity as the second line combination that we normally use. And gemtax as a combination can have more toxicity than doxorubicin as a single agent. With combination doxorubicin, ifosfamide definitely more toxic, but single agent doxorubicin can be fairly well tolerated with supportive care medications. This is again going to, when we look at subtypes of liposarcoma, we go into the real world data. And this is one of those graphs I showed you before. This is again overall survival looking at the combination versus gemcitabine alone. There seems to be an advantage for the combination. This is again our own data. One of my fellows published this, I think, a year ago, looking at, so anything below. So this is what we call a waterfall plot. At line 0 is where you start at. Each patient is 1 bar. And if the bar goes down, means that's your tumor shrinking by that much. The percentage of tumor shrinkage is on the x-axis, on the y-axis, and the x-axis is each of the patients. And of course, this, if it's going above, is not good because that means the tumor is progressing. And what you can see is blue, red is the combination, and patients with the combination, most got the combination, so we really can't make an assessment. Again, retrospective data, but this is an active regimen for liposarcoma, D. diff liposarcoma. Going on to trabectedin, again, is also has binds to the DNA minor groove. The mechanism of action is not completely known, but it does have activity, and it is FDA approved for L-type sarcomas, which is both liposarcomas and leiomyosarcomas. We did a combined, not all soft tissue sarcomas, but in this trial, we combined the two types of sarcomas, which is start with L for no other reason except that they both start with L, leiomyosarcomas and liposarcomas, but they fall under soft tissue sarcomas. And the study was comparing it to dacarbazine, which is an older chemotherapeutic regimen that we have used and sometimes combined with adriamycin in the frontline setting. And here you can see the blue line is trabectedin, again, one of those graphs. So the wider the separation between the lines means there is a bigger difference between the two agents being studied. So as you can see here, the overall survival on the right-hand side, OS, was not very different because the lines are merging. And on the left-hand side, the lines separate with a p-value. If it's less than 0.05, here it's definitely less than 0.05, it's considered significant, which means the difference is unlikely to be by chance, that it is a true difference. And here you can see that patients did not, the trabectedin was able to delay progression compared to dacarbazine. And the benefit was for both myosarcomas and liposarcomas. The benefit was seen as in all subgroups, but the highest benefit was seen in the myxoid liposarcoma subgroup. We think it's almost targeted to that, translocation somehow. This is another drug that is approved for liposarcomas. It is an inhibitor of microtubules, so blocks the mitotic or the cell division activity. This study was similar. It was done in L-type sarcomas, included both liposarcomas and leiomyosarcomas. But when the FDA looked at the data, they granted approval only for liposarcomas because when you compare to dacarbazine, eribulin had a much wider separation of the graphs in the liposarcoma group for progression-free survival and overall survival, but not for the leiomyosarcomas. Not that it's not active for that group, it's just that dacarbazine also works very well for leiomyosarcomas, hence they were not able to detect as big a difference. So this is another agent available for patients who need a different systemic regimen. So just in summary, anthracycline, which is also known as doxorubicin or epirubicin-based chemotherapy, remains the standard first-line therapy unless we have a clinical trial, as long as the patient's, performance status, what we call their ability to tolerate it, is reasonable. We would recommend that. We would use it alone or with ifosfamide based on whether we're trying to achieve a higher response rate. And the responses can vary based on the type of liposarcoma. Gemcitabine docetaxel is commonly used in second line for sarcomas, but definitely has activity in D. diff liposarcoma and pleomorphic liposarcoma. In myxoid liposarcomas, not as much. There is an oral drug called pazopanib, which is approved for sarcomas, but it does not have an indication for adipocytic sarcomas, which is liposarcomas, but in rare instances sometimes is used. And as we just talked about, the data with trabectedin and eribulin are two other new drugs available for treatment for patients with liposarcoma. So these are all approved drugs. We'll talk about a little bit about unapproved drugs now. So everyone wants to know immunotherapy and what is the activity of immunotherapy for liposarcomas. I briefly mentioned for myxoid liposarcomas, the cellular therapy or T-cell therapy. I'm not going into detail, but that's considered immunotherapy, is active for a very small subset of myxoid liposarcomas, and it's under active investigation. The other kind of immune checkpoints, which are known as the anti-PD-1, PD-L1, or anti-CTLA-4, I don't know if those terms make, but these are the ones that are approved. Keytruda, which is also known, pembrolizumab or nivolumab. These drugs, Opdivo, are approved for melanoma and a lot of other types of carcinomas, but they have only specific approvals in some subtypes of sarcoma. For D. diff liposarcoma, one of the first studies done with pembrolizumab, SARC-028, basically showed that in the D. diff liposarcoma, they expanded the cohort because they did see activity initially. The response rate, or more than 30% shrinkage, was only around 10%. So not very, and it's very difficult to select patients because some patients will respond. And again, these graphs here are for the entire group of patients, not just the liposarcomas. It's just the boxes in the bottom are highlighting the dedifferentiated liposarcoma patients among them, where the response rate, again, in the teens, basically 7 to 10, 14%. So we're still working on how to best identify these patients so we can, subject them to the benefit of immunotherapy, which has fewer side effects and can have a little bit more longer lasting effects, and not expose the majority who are going to then progress very rapidly sometimes on these therapies. So this was from our group, one of the immunotherapy studies, but we had a few of the liposarcoma patients and we did not see responses. So moving on to targeted therapies, which will, this is kind of going more into just the well-differentiated, dedifferentiated cohort, because we're going to be talking about targeting CDK4 and MDM2, which are two of the oncogenes that are highly expressed or amplified in these tumors, as I mentioned in that little segment of chromosome 12. And in the lab, at least for a long time, we have known that the mice is, in the mice, these liposarcomas that overexpress CDK4 and MDM2 respond really well to CDK4 inhibitors and MDM2 inhibitors. This is the data out there with the CDK4 inhibitors. Also, the drugs are known as palbociclib or abemaciclib, Verzenio or Ibrance. Some might have been exposed to this. The first study was with palbociclib. And here you could see this waterfall plot. Remember, you start at 0 is when you start on the study. Each bar is one patient. Very few responses. Most of the patients grew, but there are a few who respond, and it is targeted. So not as good as we see in the mice. And partly it's because the dosing exposure, CDK4 is a normal gene. It is required in your bone marrow and other areas. So you can't inhibit it completely, and you have to figure out how we can inhibit it only in the tumor so we can get high enough doses without causing side effects. So normally it's usually disease stability, and some patients might have response. Abemaciclib tends to, again, you shouldn't compare across trials, but abemaciclib seems to have a little bit more responses. You can see more bars below, and the progression-free survival was a little higher, which means, where 50% of the patients still had not progressed, was 18 weeks for palbociclib and 30 weeks for abemaciclib. So we use these drugs because they're available for breast cancer, and the palbociclib is included in NCCN guidelines, so sometimes we can get insurance to approve it. But there is a trial, this is a phase 3 trial looking at abemaciclib versus placebo, because, these are single agent trials, and it's difficult to know how much the drug is doing unless you compare it to another drug or compare it to nothing, which is what is happening in placebo. And it sounds bad that you're being exposed to a placebo drug, but sometimes when the rate of growth is slow, you need to compare it to a drug like that to actually convince people that it is working, it's doing something. And patients who are on placebo do get to cross over to the active agent. So then we talk about targeting MDM2, which is more uniformly overexpressed across all well-differentiated and dedifferentiated liposarcomas. It's almost required for diagnosis. And what is MDM2? It's basically normally, it has the activity of inhibiting P53, which is a tumor suppressor. I did mention P53 earlier because it's mutated in pleomorphic liposarcomas, which means it's not functioning well because it has an alteration in P53. In these liposarcomas, P53 is normal, but MDM2 is, you have excessive MDM2, and that is what's causing suppression of P53. So it prevents P53 from binding with its target DNA. It causes P53 to exit from the nucleus, and it degrades the P53. So you have less of this tumor suppressor, and the tumor becomes, the cell becomes a tumor cell or a malignant cell. Again, I told you in the labs, these worked really well. We've been testing multiple MDM2 inhibitors. Again, MDM2 is also in your bone marrow, so there is a toxicity, and trying to figure out the best way to dose them. It has taken a while, and it's also taken a while to try to get to the best in class, which does the correct amount of inhibition and the right amount of toxicity that the patients can tolerate at an ongoing basis. So we all, understand that meladimetan was one of the drugs, and Brightline 1 is the brigamadlin drug, which was recently reported, seems to be the one that we were seeing a lot of responses in this early phase 1 study, which had been reported previously. A lot of my patients also responded to that and were on this trial for a long time. Phase 1 trial means when the drug was first tested in humans, everybody gets exposed to the drug, and then we follow them for outcome. But when I've been treating them with other agents and they go on this and they have responses and they stay on it a long time, I know that the drug is active. But then to prove that it has activity and how much activity over standard, the company decided to run a study in the frontline setting called Brightline 1, where they were looking at comparing it to doxorubicin, which is the drug I've been talking about as the standard frontline therapy. They initially did what is known as a phase 2. So phase 1 is when they only test the drug first in humans sometimes, or they're testing a new combination, trying to find the right dose. Once they establish the dose, then they go into phase 2, where they expose more patients to it to gain more data from it. Sometimes they can even compare it to the standard. And then the phase 3 is when you increase the number of patients to make it a phase 3 so that you can have the power to detect a difference. Now, the phase 2 was almost like the initial part of phase 3. The FDA wanted them to look at 2 different doses. Both were identified as safe from the phase 1, and then choose the winner among them to actually move forward in comparison against doxorubicin. Both doxorubicin is given IV every 3 weeks, and this is an oral drug given every 3 weeks. First there were less than 270 patients, and then additional 120 patients added once we identified the 45 milligrams to be the best dose to move forward. And then patients continued for doxorubicin, they got 6 cycles. And for brigamadlin, they continued because the toxicity is not as bad, and you can continue on it for as long as you're benefiting and as long as the side effects were not too high. And it was an oral drug, so that was it's possible to continue. And then the patients were basically followed with scans and then assessing their response and also when they progressed. So progression-free survival was the primary endpoint. And again, the study was only for dedifferentiated liposarcoma patients. And the patients were randomized to those who got doxorubicin were eligible to go and get the brigamadlin. So, when you were consenting patients for a trial, you feel bad saying, oh, you'll get the standard chemo, and most of the patients are trying to escape the chemo. But in this, you can say, even if you got the doxorubicin, at least you'll get benefit from it. And if you progress, or if the tumor starts growing, you do have the option of getting this novel drug. So it accrued fairly quick, and they were able to, get all the patients accrued. And this data was reported earlier this year. Unfortunately, the primary endpoint, which when you're designing a study, you have to design the statistics and figure out how many patients you're going to need to treat based on your hypothesis. And their hypothesis was that this drug is going to be much superior compared to doxorubicin. The progression-free survival in the phase 1 study with the brigamadlin, the new drug, was around 7 to 8 months. But for doxorubicin, they estimated that the progression-free survival will be around 4 months. And this is flawed because, again, most of the prior studies are done with multiple sarcoma subtypes. And then when you look at different subsets of retrospective real-world data, different institutions, like our study, showed that the PFS of doxorubicin was high. It was like 7 months or so. But there are other studies that reported a shorter PFS with doxorubicin. Because there is so much heterogeneity within this disease, it really is a patient selection problem. So if you don't have your hypothesis right, when I look at this, I feel like both drugs are active, because patients who are progressing have not progressed. At least 50% still haven't progressed at 8 months for brigamadlin and 7 months for doxorubicin. But you see the graphs are almost touching each other, so they're not statistically significantly better. So it was difficult to convince the FDA to approve it in this setting. That being said, if patients have had doxorubicin, or are ineligible to get doxorubicin because of other issues, you could always have this drug after. But for that, it'll take another study and more funding to actually run those studies. So this is by what we call the first graph I showed you was based on what the central review, so they want to blind the person who's treating you from the outcome. They have a central review investigate what is the outcome. But the investigator can also look at the scans and give their assessment of what they think is best for, or which one's working the best or still working. And in this situation, sorry, my phone is going on. I'll shut it off. So the investigator felt that the brigamadilin was a little bit more superior, but still not statistically significantly better than doxorubicin. This is the waterfall plot again. And as you can see here, that the number of patients whose tumor shrank was actually higher, was 22% with the brigamadilin, the new oral drug, compared to around 9% with doxorubicin. So doxorubicin was active, but this one had more tumor shrinkage, but that was not the primary endpoint the way the study was designed. So while interesting, doesn't help with the approval process. It's also important with any drug, when you have discussions with your oncologist, is to know what the side effect profile is, right? How do you make a decision about what is going to work with your quality of life unless you know what the side effect profile is? And brigamadilin is not without toxicity. It does cause some nausea. It can also drop blood counts, but the nausea diarrhea extent is usually around the dosing, and there is a benefit of being able to take the drug orally. A lot of patients will, worry about hair loss, which of course happens with doxorubicin, but doesn't happen with brigamadilin. For doxorubicin, most of the side effects are quite acute for that 1 week, but then they start getting better. And the same holds for brigamadilin. So I would say both. While looking at this, I would love to have access to both these drugs to treat my patients in whichever sequence I think best, because some might work best for one and some might for the other. I'm going to skip this. I just put in this case just to highlight a journey of a patient with dedifferentiated liposarcoma, but I want to leave time for questions. Sorry, I got carried away in my talking, so I missed. I wanted to leave at least 15 minutes for question and answers. But this is a patient of mine who've been treating since 2015. I gave him chemotherapy before his first surgery because it was very extensive. We were trying to save his kidney, wanted it to shrink, but he did not have. He did not have a great response with the doxorubicin ifosfamide. So even though I showed that some patients can benefit, not all do. Then he went and got gemcitabine docetaxel and had this, he got it locally and had some unusual hearing loss, which is not common at all. And then just went in for surgery, and then we followed him. He recurred, and then I've treated him with many different therapies, trying to give him access to everything. He got one other trial that was run before with selinexor, had some benefit. He got on my immunotherapy trial, but was on it for, again, just 3 months. Had eribulin and got a good response with eribulin. And then he started the brigamadilin study. He was on this oral drug, and he started in 2023, in June of 2023, and is still currently on this drug. And I'll just show you this image. This is when he started out in May of 2023, and this was just basically 4 months later. You can see the PET active disease really shut down with brigamadilin here, and he still continues with this response even now. I will end there, and I will say, it is really tough navigating a cancer diagnosis. It's even tougher navigating a diagnosis of a rare tumor. And it creates challenges not only in the workup, and the diagnosis of the disease, it's the treatment. You have to go to expert centers. It's difficult to find care closer to home. But I hope in the future, with more advocacy for rare tumors, we can figure out a way to work together where, through advocacy groups, getting care to you wherever you are, through experts within the advocacy groups or other rare tumor consortia. So I will end there. Sorry for going a little over time, but I hope I can get through most questions. And I will stop sharing, so that'll be easier.
Thank you so much, Dr. Smaya. I think that let's start with the 4 questions that were asked today. There were a couple of questions that were sent in advance, and I think we'll try our best to see if you can answer them via email afterwards. As a reminder, everyone should join the Liposarcoma Support Network. You can just find us online. I'll send the link in this afterwards, and you can sign up for a newsletter and more programs and more information like sessions like this. All right, Dr. Smaya, the first question, are the normograms like the circulator a good tool for evaluating patient prognoses?
Yes, so the circulator is good for, again, it is to evaluate whether you should get chemotherapy after resection of tumor or not. Now, it works for liposarcoma, it works for, it's a risk of recurrence, right? It's assessing your risk of recurrence and then deciding if your risk of recurrence is high based on the grade, size, and other features or the subtype, then should you get chemotherapy or not? It works for myxoid liposarcoma, well, pleomorphic liposarcoma. For well-differentiated, dedifferentiated liposarcoma, the sarcoma community usually does not give chemotherapy after surgery. So if the only reason because the response to chemotherapy is relatively low, right? For myxoid liposarcoma, it's 50 to 80%. For dedifferentiated liposarcoma, it's around 20%. So, I'm not saying it's zero, and a lot of patients might benefit, but the recurrence pattern of well-diff, D-diff liposarcoma is different. Your recurrence could be in 3 months, but your recurrence could be in 3 years or 10 years. And it's very difficult for us to pick out which patient is going to benefit from the chemotherapy after surgery. And we our basic thing is don't do harm. So we would not expose you to chemotherapy if we didn't feel that it's going to make a difference. So as of now, for circulator can be used, but depending on your type of liposarcoma, it also is important to use oncologist with sarcoma expertise to make that decision.
Cool. Second question is, does the presence of sclerosing cells classify a well-differentiated retroperitoneal tumor as more aggressive, even if it does not present mitoses or necroses?
So I would say yes, and there is more and more data. So, now when we're doing studies, we're trying to actually identify the type of well-diff liposarcoma and then analyze them even when we're looking at their genomic or spatial, features of these cells. So the short answer is yes, but it will take bigger studies to actually prove that we can alter that outcome. We can make it less aggressive by treating it like a dedifferentiated liposarcoma.
What are your thoughts on myxoid pleomorphic liposarcoma, as it's like a newer subtype and rarer subtype of liposarcoma? Is the treatment protocol similar?
So the treatment protocol is similar, but we know less about the prognosis or outcome. So this is for people who are not aware. So, I talked about these various subtypes. And so there is a myxoid pleomorphic liposarcoma, so myxoid liposarcoma that looks like a myxoid liposarcoma, but doesn't have a translocation. So it doesn't have the characteristics of a true myxoid liposarcoma, and pathologists are now classifying this as it's a liposarcoma, and it's fairly recent that this subclassification has come around. So we don't know much about it. We still have to look at the outcomes, and previously we were not doing the translocation testing on everyone. So we don't know the data we have from before, how many of the myxoid pleomorphic liposarcomas were included in the previous studies. So I think just as we learn more, we'll learn more about this rarer subtype of liposarcomas.
This patient has multifocal liposarcoma in the retroperitoneum and is inoperable. They've had 5 recurrences. There is it looks like a high growth rate that could be dedifferentiated, but the biopsy has shown that it's well differentiated. I think that you talked a little bit about lines of treatment, and I know this is a personal question, but yeah, I would love your thoughts on treatment options.
So again, it depends if the patient has had prior treatment or not, right? I just went through all the different, in this situation, when it's inoperable, if it shows well-diff liposarcoma, but it is hot on PET, it might still be reasonable to try one of those systemic chemotherapy lines, because as we said, biopsy is not always accurate in detecting this. And if the PET is active, you could actually follow that disease with PET on therapy. You can get chemotherapy and after 2 cycles see the response. If it's truly well differentiated and it was not active on PET, I have used CDK4 inhibitors, and if you could get on a phase 1, there are these MDM2 degraders that are coming up in phase 1 trials, so access to something targeted like that might also be useful.
How long into a chemotherapy cycle does it take to see if the patient is having a response, whether they will be one of those who has positive response?
So we usually say, of course, sometimes you can be lucky where you have a palpable tumor and you immediately see that it gets softer or you feel better, but it's very difficult based on symptoms because you're having chemo symptoms, right? And like you're feeling terrible for that first time. But I would say 2 cycles is what we say is the earliest time that you should assess, unless you have worsening of symptoms that really is concerning us, then we could do a scan sooner. But otherwise, usually 6 weeks, because most cycles are 3 weeks, and 6 weeks after starting. It's also very important that the scan that you have prior to the one that you're comparing to is not too dated. It has to be close to the time when you actually started the chemo, so you could have a proper assessment of what the chemotherapy is doing.
Is a PET scan effective for showing myxoid round cell liposarcoma, or is an MRI better, specifically on the scalp, and can low vitamin D signal a sign of recurrence?
So for myxoid liposarcomas, it varies. Again, there is a higher grade cellularity known as round cell or higher grade of round cells. And that, higher grade tumors within myxoid liposarcomas will light up on PET. But if you have not had a baseline, before treatment, if you've not had a PET, doing a PET after might not be helpful, because if your tumor was not PET avid, your recurrence might not be PET avid and you might miss it. So in those situations, an MRI and a CT, that is contrasted CT, would be better. Whether low vitamin D levels can signal recurrence is not yet established. It's good to look at your vitamin D levels. It's part of health screening now, and a yearly health screening by PCP, and almost all of us are low in vitamin D. So getting that corrected is good because that has health benefits, and low vitamin D can be detrimental. But I don't know. We don't know yet if it is related to recurrence.
Okay, sounds good. We do have 3 more questions. I think maybe we'll try to breeze through them, but I think anything that comes after this, we will try our best to follow up afterwards. Can you comment on the efficacy of proton radiation therapy as opposed to IMRT or SABR for dedifferentiated?
Yeah. So again, proton radiation, of course, it's a different, it's a type of radiation, but they're using different photons, right, to get. So this is a question for a radiation oncologist. For majority of tumors with D. diff liposarcoma, based on where they are and based on if they're large, it would be regular radiation therapy, which is IMRT. Proton therapy can be used on a case-by-case basis, depending on the location, because there could be downsides of proton therapy. So it's not universally better than IMRT. So you need a discussion with the radiation doctor.
Could you talk a little bit about idea of recurrence time for dedifferentiated, percentage, average time of recurrence, and then follow up whether it should be CT or MRI?
So the recurrence rates of D. diff liposarcoma, as Christine also knows me telling, is usually high. It's more than 50% chance of recurrence over your lifetime. Some series will report as much as an 80% recurrence. And that is but depending on the grade and how your tumor is behaving, sometimes it could be 3 months, it could be a year, and some people, when you detect it early, it could be much later, 5 to 10 years. So we continue to follow them, and the frequency of following patients, we keep extending that just based on the patient's tumor characteristics and how long they have been disease-free for. In terms of what is the best modality of assessing for recurrence, again, most often it recurs in the same area. So if your tumor arose in the retroperitoneum, we have to do more frequent abdominal pelvis scans. If it's the extremity, then we have to do extremity scans. And occasionally we'll include the other types just to make sure, other organs like the chest, to make sure nothing's there. But we don't have to be very frequent. For a contrasted CT scan is actually very good, and most oncologists can also look at it. So we prefer that for assessment, but an MRI is equally good. For extremities, MRI is actually preferred. For the abdomen, pelvis, also MRIs can be great. You just need an expert radiologist who can look at the contrast and the difference to try and tell you what looks more high grade, what looks low grade.
Good. Well, thank you so much, Dr. Samaya. And thank you everyone so much for joining. I think that definitely our goal here is to be able to give broader access to expert knowledge, like such as Dr. Samaya's, but also anyone else's sort of like expert sarcoma doctors that you see. And I think that we will definitely be doing more events like these with the Liposarcoma Support Network. So definitely sign up for the newsletter, sign up for us join the membership online. Everything is free. And we will send out more information. We'll definitely send out this recording to the group that registered, as well as on all of our social media. But thank you all so much. Really appreciate it. And thank you, Dr. Samaya. So we'll see you all soon.
It's a pleasure. Advocacy is a big help to patients and also to the research community. So I can't thank you enough.